Hello everyone, this is Dr. Shiwani Chaturvedy. In this lecture, I will be discussing about preoperative workup of a cataract patients. The preoperative assessment or workup of a cataract patient should be a step-by-step approach. First, we need to take a thorough ocular and systemic history followed by good complete clinical examination and appropriate calculation, and patient needs to be advised suitable laboratory investigations, meanwhile preparing the patient for the surgery. Ocular history is very important. When patient is coming to you, you need to ask the history of presenting illness, where the visual decline is for far or near or both, how it started, if it is associated with any glare, starburst, or if it is worsening during the daytime or during the night time. Also, if it is associated with monoocular polyopia, and that may guide you with the type of cataract and the progression. Also, in ocular history, you need to see previous glass prescriptions and rule out amblyopia. Ask the patient about any history of ocular trauma or uveitis. So the surgeon will be prepared for intraoperative poor pupillary dilatation or posterior capsule weakness. Family history of glaucoma and retinal detachment. So the patient must undergo a thorough fundus evaluation and also see the available previous eye records. And don't forget to ask the patient's expectations from the surgery. Systemic conditions and medications must be evaluated before going for cataract surgery. That will influence the anesthesia and intraoperative safety. If the patient is diabetic and on poor sugar control, it might increase the risk of post-op infections or may interfere with wound healing. And in renal failure or renal transplant patients, the patient will be on immunosuppressive drugs for very long. That might also increase the risk of post-op infections. And if the patient is having breathing difficulties, we should avoid the drugs that may precipitate bronchospasm. Also ask if the patient is a smoker or alcoholic. And if the patient is on antihypertensives, just make sure to have good blood pressure control before going for the surgery. And antihypertensive drugs are usually continued during the day of the surgery also. And if the patient is on blood thinner, the decision to stop them depends on the type of drug and the cardiologist opinion. Usually they are stopped 5 to 7 days prior to the surgery. Also ask if the patient is on alpha-1 antagonist like tamsulosin, which is associated with intraoperative floppy iris syndrome. These drug causes the paralysis of pupillary dilator muscles, and the surgeon should be prepared with pupillary expansion devices and iris hooks. And also ask about the history of any hypersensitivity or reaction to any medications. Now, don't forget to assess the patient cooperation. Like if the patient is having any disorder which is causing the tremors, or the patient is not able to lie down straight, or having excessive anxiety or fear, these things must be tackled before going for the surgery. Coming to most important, the clinical examination. Visual acuity is first and foremost thing to confirm, and it should be checked both for distance and near. And if the patient is not able to read any charts or even near face, please confirm perception of light or projection of rays in all directions, as this is the one single method that will give you a gross idea about retinal health. The initial external ocular examination is done using a torchlight, which helps to identify gross abnormalities, assess for facial asymmetry that may indicate previous facial nerve palsy, which is important for eyelid closure and post-operative care, and look for any abnormal positioning of eyes. And if the patient has deep-setted eyes, which is common in elderly patients and is associated with difficulty in surgical access. And if the patient is having dermatochalasis, that is redundant eyelid skin, which is very common in elderly patient, it can interfere with the eyelid opening. And check for extraocular movement in all the directions. That may help you to rule out any paralytic squint. A good thorough slit lamp examination is very important before cataract surgery, and the aim is to rule out any potential source of ocular infection and optimize the ocular surface before going for cataract surgery. Now, starting with lid abnormalities, we must see if the patient is having ptosis or lag ophthalmos. which might cause exposure keratopathy. And if the patient is having blepharitis or myomitis, that can act as a reservoir of infection and may increase the risk of post-operative endophthalmitis. And the treatment should be started before the surgery. And please do check Roplast test before going for cataract surgery. And lacrimal syringing will help to assess the lacrimal patency. And if the patient is having abnormal tear film or dry eye, then it will lead to pre-operative biometry inaccuracy, and it will affect the post-operative visual quality, and it should be treated before going for surgery. Also, if the patient is having chronic dacryocystitis, the cataract surgery should be deferred, and DCR or DCT should be done prior to cataract surgery to reduce the risk of post-operative endophthalmitis. And if the patient is having entropion or misdirected lashes, that can cause corneal irritation and infection and should be corrected before cataract surgery. Coming to cornea, see if the patient is having arcus senilis, note how broad it is, and if the patient is having corneal dystrophies and degeneration, that will increase the risk of post-operative corneal edema, and assess the location and density of corneal opacity, as central corneal opacity will obscure the red reflex and make the capsulorhexis difficult. And if the cornea has pigments and capies on endothelium, that indicate previous uveitis, which will increase the risk of post-operative inflammation. In anterior chamber, note if the chamber is shallow, that will reduce the safe working space for phacoemulsification and increase the risk of endothelial damage, and requires adequate use of OVDs to protect the endothelium and create space. And if the chamber is very deep, which is common in high myopes, that will cause a difficulty in nucleus manipulation and increase instrument excursion, and requires modification of surgical technique. Iris, we need to see the area of iris atrophy or neovascularization. Iris neovascularization is commonly seen in ischemic conditions. And C for iridodonesis, which is very common in pseudoexfoliative patients. And in pupil, we need to see if there is any posterior synecdoche or meiosis, which is common in uveitis, which causes poor dilatation and increases the surgical difficulty. Also check for pupillary reaction. The sluggish response suggests sphincter dysfunction, and RAPD indicates optic nerve or retinal pathology, which is important for assessing visual prognosis. Also rule out pseudoexfoliation syndrome, which will lead to poor pupillary dilatation and weak zonules. That the surgeon must be prepared with pupillary expansion devices, iris hooks, and also capsular tension rings to help stabilize the capsular bag and reduces the complication risk. Finally, coming to cataract grading, using LOCS3, which allows the objective assessment of lens opacity. And in nuclear cataract is graded based on color and opalescence from grade 1 to 6. The cortical cataract is graded from grade 1 to 5, and the posterior subcapsular cataract is graded from grade 1 to 5. And the posterior polar cataract needs a special mention here because the posterior polar cataract is associated with weak posterior capsule that can cause posterior capsule rupture, and we need to counsel the patient regarding this, as this will affect the post-operative visual outcome. And please assess zonular status based on phacodonesis and iridodonesis, as this can cause lens instability and intraoperative complications. Intraocular pressure assessment is very important part of routine preoperative workup of cataract surgery. The IOP is measured by applanation tonometry, which is a gold standard, and it helps in identifying the undiagnosed glaucoma or ocular hypertension. If the IOP is elevated, it should be controlled before surgery because it can lead to optic nerve damage or intraoperative complications and postoperative pressure spikes. Also, the IOP should be closely monitored in the postoperative period. Do not forget the importance of a thorough fundus evaluation, as this will help in determining the visual prognosis, planning additional referrals, or avoiding the post-operative dissatisfaction due to unexplained poor vision. It is usually done by indirect ophthalmoscopy or slit lamp biomicroscopy using 90 diopter lens. And we should look for congenital and developmental abnormalities, any degenerative retinal diseases like ARMD or myopic degenerations, and these must be identified and explained to the patient preoperatively. The retinal pathologies which are evaluated include diabetic retinopathy, CRVO, BRVO, hypertensive retinopathy. The presence of these conditions may require preoperative retinal treatment. And also look for optic nerve pathology like glaucomatous cupping, optic atrophy, or AION. These conditions can significantly affect visual outcome even after cataract extraction. We encounter dense or mature cataract and we are not able to see the retina at all, we turn to B scan. Our primary goal here is to rule out any posterior segment pathologies that could significantly impact the surgical visual outcome of the patient. We specifically look for retinal detachment as shown in the middle image and vitreous hemorrhage as shown in the third image, or any posterior staphyloma or tumors. It helps us decide if we need a retina specialist on standby or if the surgical approach needs to be modified, and also counsel the patient regarding this. Coming to the essential ocular measurements required for a precise preoperative workup. The first one is biometry, which includes keratometry, that is measurement of corneal curvature, and axial length measurement, that are the foundations for selecting correct IOL power and the refractive outcome of the patient. Then specular microscopy, which helps in evaluating the health of corneal endothelium and ensure the eye can withstand the surgery. Then ocular coherence tomography, which screens the macular issues that could limit a patient's vision. And lastly, pentacam, which provides advanced corneal mapping, which is essential for managing the astigmatism and planning premium IOLs. Now, biometry relies on two main pillars, keratometry and axial length measurement. Keratometry can be performed using manual or automated methods. Always take an average of 3 readings for maximum precision. And the patients who are using contact lens, to allow the cornea to return to its natural shape and for corneal stabilization before biometry, patient must stop wearing soft contact lenses for at least 1 week and hard contact lenses for at least 2 weeks. Now, A scan, that is amplitude scan. In brief, it is a one-dimensional ultrasound used primarily to measure the axial length of the eyeball, which is critical for IOL power calculation. And it uses the sound waves and includes applanation, probe touches the cornea, and immersion methods. And the immersion technique has the advantage that it avoids corneal compression, which can artificially shorten the axial length measurement. Also, it is specifically preferred for dense cataracts and high myopia. Also, most of the axial length fall within the range of 21 to 25 millimeters and K readings within 40 diopters to 48 diopters. And measurements should be repeated if the axial length is below 21 or more than 26 millimeters and mean corneal power is less than 41 diopters or more than 47 diopters. And also if the difference in the axial length between the fellow eyes is more than 0.7 mm and difference in the mean corneal power is more than 0.9 diopters. Once you are done with the history and examination part, the patient needs to undergo some laboratory investigations that includes routine blood counts, blood sugar estimation, which includes random blood sugar, postprandial blood sugar, and HbA1c. That will give you an overall idea about the blood sugar control. Also urine routine and microscopy to rule out any potential source of infection. ECG needs to be done because peribulbar block tends to give rise to bradycardia and the patient safety is our priority. Also triple viral marker test, and we are dealing with the geriatric population mostly, which tend to have multi-systemic diseases, and that needs to be optimized before going for the cataract surgery. Lastly, preoperative preparation, that includes informed consent, which must provide detailed information regarding the procedure, potential risk, and expected visual outcome. It should be communicated in the patient's regional language for full transparency. And also we should guide the patient regarding the hygiene, and the eye intended for the surgery must be clearly marked to prevent the wrong site errors, and the patient must change into clean operating room clothes immediately prior to the procedure. The objective with these protocol is to prevent post-operative endophthalmitis. The topical antibiotics we typically use fourth generation fluoroquinolones is either administered every 15 minutes for 4 to 6 times immediately before surgery or started 2 to 3 days prior to the surgery. And also povidone iodine 10% is used for skin disinfection. We use it to paint the eyelids, brow region and surrounding facial skin. This should be performed 3 hours before the surgery to ensure sterile surgical field. And the conjunctival sac is irrigated with 5% povidone iodine. Coming to anesthesia, for topical anesthesia, we commonly use drops like Preoperative 0.5% or Tetracaine 0.5%, sometimes supplemented with lidocaine 2% gel. The advantage of no injection approach is that it eliminates the risk like globe perforation or retrobulbar hemorrhage. It also offers fastest recovery and is ideal for standard uncomplicated phaco cases. The limitation is that it does not provide akinesia, so it requires a cooperative patience and also provide limited analgesia for deeper intraocular structures. Now, peribulbar block, which is very commonly used, in this a needle is inserted at the junction of lateral 1/3 and medial 2/3 of the lower orbital margin. We typically use a mixture of lignocaine and bupivacaine with hyaluronidase to aid spread, followed by 3 to 5 minutes of orbital pressure. The advantage is that it provides excellent akinesia and analgesia because the injection stays out of the muscle cone. It carries a lower risk of optic nerve damage compared to retrobulbar block. The limitation is that it requires a larger amount or volume of anesthetic and may have a slower onset than other blocks. Multiple injection sites are sometimes needed to achieve complete block. Now coming to subtenon's block, a blunt tipped cannula is inserted into a potential space between tenon's capsule and the sclera through a small conjunctival incision roughly 5 mm from the limbus. The key advantage is that we use a blunt cannula, so there is less risk of any complication and it is generally less painful and preferred option for patients on blood thinners, and the common side effect is subconjunctival hemorrhage and chemosis. Now coming to retrobulbar block, a needle is inserted at the junction of lateral 1/3 and medial 2/3 of lower orbital rim and directed backwards and upwards into the intraconal space. This block provides very rapid onset of both anesthesia and akinesia, offering excellent analgesia for intraocular surgery. While effective, it carries more serious complications risk, which includes retrobulbar hemorrhage, globe perforation, or optic nerve injury. Now, in brief, about some special circumstances that what to do when we are dealing with these patients, like patients having some certain anatomical features like deep set eyes or big brows, which makes the standard superior access challenging. We can overcome this by making a temporal incision or tilting the patient's head. Or if we are dealing with dense nuclear cataract, the surgery requires increased phacoemulsification time and increased energy. This poses a higher risk of post-operative corneal edema and also intraoperative complications because we are operating in a high energy levels. So we can mitigate this by using a soft shell technique for advanced endothelial protection and employing low or moderate fluidics to maintain the chamber stability and also to protect corneal endothelium. To pupillary challenges, when we are dealing with small pupil, small pupil significantly hinders the visualization of the lens and the capsulorhexis. Poor visibility increases the danger of accidental capsule rupture or rhexis runout or direct damage to the iris. To achieve adequate exposure, we can use viscomydriasis or pupillary expander devices or iris hooks. And if we are dealing with a patient with posterior synecdoche, that are adhesion between the posterior iris and the anterior lens capsule, which is often resulting from the previous inflammation, the synecdoche can lead to intraoperative meiosis, prolonged postoperative inflammation, and iris bleeding while we are trying to dilate, and the formation of inflammatory deposits on the new intraocular lens. Mechanically, we can manually break the adhesions using iris hooks, or pupil expanders or performing minor sphincterectomies. And also post-operatively, these patients require more intensive topical steroids to deal with the inflammatory response. Coming to posterior polar cataracts, which are often associated with weak or defective posterior capsule at the central pole, the capsule may already be open or extremely thin. To avoid the posterior capsule rupture, we must avoid hydrodissection as the fluid pressure can easily blow out the weak capsule. Also use low Pueco parameters to maintain the chamber stability and reduce the stress on the capsule. And if we are dealing with a white mature cataract, the primary difficulty is that lens is swollen and milky and there is lack of red reflex, making it nearly impossible to see the capsule during the rhexis. We can manage it by good capsular staining and viscotamponade and needle decompression. What is it? To manage the high internal pressure of the intumescent lens and prevent Argentina flag sign, we use a heavy viscoelastics and a needle to aspirate the liquefied cortex before completing the rhexis. To conclude, a thorough workup is the foundation of a successful surgical outcome and patient satisfaction. Thank you.